Hello everyone, this video we are going to see about osteoradionecrosis. So first things are first. So what is osteonecrosis? So in Greek words, osteo means bone, necros means dead and osis means condition. So meaning that destruction and death of the bone tissue. So when the osteonecrosis of the jaw occurred after irradiation or after radiation, it is called as osteoradionecrosis, or when it occurs after medications like bisphosphonates, it is called as bisphosphonate related osteonecrosis or medication related osteonecrosis of the jaws. It is also called as osteochemonecrosis. So the osteoradionecrosis was first published by Raygaard in the year 1922 about the osteoradionecrosis of the jaws after radiotherapy. Coming to the definition of osteoradionecrosis, there are various definitions that was given by various authors, but this is the most accepted definition. So this goes as area of exposed irradiated bone tissue that fails to heal over a period of 3 months without residual or recurrent tumor when other causes of osteonecrosis have been excluded. Meaning that clinically there should be an exposure of irradiated bone tissue. It should be in the irradiated field and it should be present over a period of 3 months, and there should be no recurrence of residual or recurrent tumor, and when other causes like bisphosphonates or other medications which can cause osteonecrosis should be ruled out. Only then it should be called as osteoradionecrosis. Coming to the etiological and risk factors for development of osteoradionecrosis. Posterior mandible and mandible as such is most commonly affected by osteoradionecrosis because of its compact and dense nature, and also the mandible is supplied by inferior alveolar artery, whereas in maxilla it is supplied by anterior, middle, posterior superior alveolar arteries and as a much of a collateral blood supply. And usually the mandible is most commonly associated with the proximity of the tumor bone. It is lie closely to the tumor bone and it is present at the irradiated field. So because of these causes, mandible is more commonly affected by ORN. And then poor oral hygiene during irradiation therapy or after irradiation therapy can make the bone more vulnerable to develop osteoradionecrosis, and then radiation dosage that is more than 50 to 60 gray units make the bone more vulnerable to develop osteoradionecrosis. Then the type of radiation therapy like brachytherapy and external beam radiation therapy can increase the risk factor for development of osteoradionecrosis. The brachytherapy is nothing but a localized form of radiation therapy, as we could see in the right side picture, where the needles of iridium or cobalt implants are placed within the tumor field and radiation is given particular to that field. So when this field is proximity to the mandible or jawbone, it can result in formation of osteoradionecrosis. And external beam radiation therapy, as the name implies, the radiation is given from the distance to the tumor. So it is not targeting a particular tissue. So it will be affecting the other jaw bones also other than the tumor sites. So this can also increase the risk factor for osteoradionecrosis. But IMRT, the recent modality, radiation therapy modality, that is intensity modulated radiation therapy, reduces the risk factor for development of osteoradionecrosis because each beamlet of the radiation is modulated according to the target tissues. So because of that, we can reduce the dosage to the bones and surrounding normal tissues. We can able to avoid the risk factors for the development of osteoradionecrosis. Then nutritional status. So the compromised nutrition can decrease the cellularity and regenerative potential of the tissues. So this can also increase the risk factor for osteoradionecrosis. Then concomitant chemoradiation therapy. So usually in oral cancers, the patient will be going radiation therapy along with chemotherapy. So or in case of metastatic diseases, the patient will be going for chemotherapy along with radiation therapy. So in those cases, it increases the risk for osteoradionecrosis. Then chronic trauma due to ill-fitting prosthesis can also make the bone more vulnerable to develop osteoradionecrosis. Then acute trauma from any extraction procedure after radiation therapy can increase the risk factor for osteoradionecrosis. So how this osteoradionecrosis develops? So what is the pathophysiology behind it? So Marx in 1983 introduced the 3H concept of development of osteoradionecrosis that includes hypocellularity, hypoxia and hypovascularity. So let's see what is it, what is the 3H concept. So when the tissues are irradiated, it causes two types of damage. One is direct damage and another one is indirect damage. So in direct damage, the X-rays and gamma rays directly damage the macro and micromolecules of the tissues, whereas in case of indirect damage, it causes radiolysis of water, that is nothing but hydrolysis of water in the body by irradiation, resulting in formation of free radicals. That free radicals damages the micro and macromolecules of the tissues. This is the basis of any radiation damage of any biological tissue. Likewise, in case of osteoradionecrosis, when the bone tissues are irradiated, either directly or indirectly, it can cause damage to the bone tissue components, mainly osteoblast, osteoclast, and osteocytes and fibroblasts. So these are the cells which has a reparative function of a bone. So whenever the bone is undergoing remodeling, these cells helps in remodeling and reparative function of a bone. So these are affected by either direct or indirect damage to the bone, and also it affects the blood supply of the bone. So the irradiation causes damage to the endothelial cells, which results in thrombosis of the vessels and causing hypovascularity to the bone, which gradually resulting in ischemia of the bone tissue and hypoxia of the bone. So this is how the radiation causes hypocellularity, hypovascularity and hypoxia in a bone. So after all these happens in after irradiation of a bone, whenever there is a micro trauma or a macro trauma, so the micro trauma could be any trauma during mastication or patient undergoing acute extractions or any chronic ill-fitting processes. All these can result in forming chronic non-healing wound, which is nothing but the osteoradionecrosis in a already vulnerable bone. Coming to the clinical presentation of osteoradionecrosis. So as the definition implies, it is the exposed necrotic bone that is the hallmark feature of osteoradionecrosis. So we can see, as we see in this picture, there will be loss of mucosal covering and there will be exposed necrotic bone. Sometimes in severe cases there will be extraoral sinus or fistula, and there will be osteolysis of inferior border of the mandible and can result in pathological fracture in severe cases. And along with, the patient will be complaining of pain, halitosis and trismus, which is difficulty in opening the mouth and difficulties in chewing, swallowing and speech. Osteoradionecrosis is more of a clinical diagnosis. We can able to identify the clinically exposed necrotic bone along with the history of irradiation. We can able to diagnose the osteoradionecrosis. But radiological investigations are necessary in order to identify the severity and extent of osteoradionecrosis, and also helps us to monitor the prognosis of the treatment. So the conventional radiographic techniques like panoramic radiography is helpful in order to identify the extent of the bone, and computer tomography can help us to assess the extent of the bone in three planes, that is the axial, coronal and sagittal planes. And MRI is also helpful in initial stages where there will be an inflammation of marrow contents without any resorption of the bone. So in that stages, MRI is also helpful. MRI diffusion weighted imaging can be helpful to assess the difference between the recurrence of the tumor and osteoradionecrosis. So the radiographic features of osteoradionecrosis in the panoramic radiography shows there will be rarefaction of the bone as we see in this picture, and there will be lytic areas along with the sequestrum formation. So sequestrum is nothing but the isolated dead and necrotic bone, which will be seen as a sclerotic bone surrounded by the rarefaction or lytic areas. And in some severe cases, there will be cortical break and there will be pathological fracture resulting in extraoral fistula. So these are the features of osteoradionecrosis in panoramic radiography and in multi-detector CT. Here we can see the CT images of axial and coronal section of osteoradionecrosis. Here in the left side picture we can see the sequestrum formation and lytic areas of the bone. Along with, in the right side picture, coronal section shows a cortical break or pathological fracture. Usually, we see this osteoradionecrosis in a post-irradiated patient who have been treated for oral cancers. So, how do we know whether it is a tumor recurrence or osteoradionecrosis? So, Ermans et al. Shown that when the osteoradionecrosis or exposed necrotic bone distant from the position of the original tumor area, and if it is present on the contralateral side, that means in the opposite side, it is mostly of mandibular osteoradionecrosis or osteoradionecrosis of the jaw rather than the recurrence of a tumor. And also the other imaging modalities like PET and SPECT imaging, these are the molecular imaging, and also the diffusion weighted imaging of MRI can help us to identify whether it is an osteoradionecrosis or a tumor recurrence. Next is management of osteoradionecrosis. So the main goal of osteoradionecrosis treatment is removal of necrotic or dead bone and then enhancement of the vascularity of the remaining irradiated damaged tissues. Initial management of osteoradionecrosis includes local irrigation of normal saline and 2% chlorhexidine mouth rinses, and also systemic antibiotics in order to control the superimposed infection which can aggravate the osteoradionecrosis. And patient should be educated about avoidance of tobacco and alcohol, and if the patient is wearing any denture that is causing the oral trauma, that should also be avoided, and educating the patient about oral hygiene instructions. So, along with this initial management, gentle debridement of the sequestrum is done. If the patient is not responding to this initial conservative measures, then going in for a surgical therapy and hyperbaric oxygen therapy is essential in order to limit the severity of osteoradionecrosis. What is hyperbaric oxygen therapy and why it is used in the treatment of osteoradionecrosis? So, hyperbaric oxygen therapy was first introduced in the year 1973 by Greenwood and Gilchrist. So, as we have studied in the pathophysiology of osteoradionecrosis, where hypovascularity and hypoxia is one of the predominant feature in the development of osteoradionecrosis. So, hyperbaric oxygen therapy uses 100% oxygen in order to overcome the hypoxia and to increase the vascularity. And other benefits of hyperbaric oxygen therapy is when we are increasing the vascularity, it induces angiogenesis in the compromised tissue, and also it enhances the recruitment and function of leukocytes and inhibits the aerobic and anaerobic bacteria, so that superimposition of infection is also affected, and it also increases the reparative potential of tissues. But how it is used? So, Marks and Eames have devised a protocol for the treatment of osteoradionecrosis by the use of hyperbaric oxygen therapy. So, let's discuss in further slides. Marks and Eames first outlined the standard approach for the treatment of osteoradionecrosis by the use of hyperbaric oxygen therapy and named that protocol as a Wilfred All protocol. So it consists of three stages: stage 1, stage 2 and stage 3, and stage 3 can be again divided into stage 3R. So stage 1 protocol is devised for mild cases where total of 30 hyperbaric oxygen exposure is given at the 2.4 atmospheric absolute pressure for 90 minutes. So after 30 dives of hyperbaric oxygen exposure, patients are examined for signs of improvement. So signs of improvement such as wound healing closure or decrease in the exposure of non-viable bone. So all these are examined and patients are labeled as either stage 1 responders or stage 1 non-responders. So if patients are responding to the stage 1 protocol, additional dives up to 60 hyperbaric oxygen exposure is given, and if the patient are non-responders, then they are transitioned to stage 2 protocol. Stage 2 protocol consists of 30 hyperbaric oxygen exposure along with transoral debridement, that is a removal of necrotic bone or sequestrectomy, and additional 10 sessions of hyperbaric oxygen exposure. Even though the patient is non-responsive to stage 2, then the patient is transitioned to stage 3. Stage 3 protocol is mainly devised for recalcitrant cases and also severe cases of osteoradionecrosis. So it consists of hyperbaric oxygen therapy along with mandibular resection and fixation, or stage 3R consists of bony reconstruction followed by soft tissue coverage and additional hyperbaric oxygen therapy of 10 dives post-operatively. So this is the overview of Marks and Eames protocol for osteoradionecrosis management using hyperbaric oxygen therapy. Recent studies have also shown that pentoxifillin and vitamin E capsules can also be used in the treatment of osteoradionecrosis along with hyperbaric oxygen therapy and other conservative measures. So, pentoxifillin is a vasodilator which decreases the blood viscosity and improves the tissue oxygen level and hypoxic conditions. And vitamin E capsules, it's an antioxidant which scavenges the reactive oxygen species or free radicals released by the radiation. So these two agents can also be combined with hyperbaric oxygen therapy and has improved results. Another recent modality that has been used in the treatment of osteoradionecrosis is therapeutic ultrasound. Therapeutic ultrasound exerts its physical effects through two mechanisms. One is thermal and one is non-thermal. In osteoradionecrosis, non-thermal effects have been used for tissue regeneration and improving the vascularity and improving the hypoxic nature of the tissues. So Harrisel et al. Used ultrasound of 3 MHz pulsed for 40 sessions of 15 minutes per day, which showed improved results in the treatment of osteoradionecrosis. So far, we have discussed about the pathophysiology and management of osteoradionecrosis. But how do we prevent osteoradionecrosis and what are the preventive measures that should be taken before patients going for head and neck radiotherapy? So first of all, patient should be referred to dentist and pre-treatment assessment should be done and patient should be counseled about good dental management and good oral health and regular follow-up should be required during radiation therapy and also after radiation therapy. And grossly carious teeth, periodontally hopeless teeth, and which has a poor prognosis should be removed atraumatic as possible. Along with alveoloplasty should be done with a primary closure. So all these should be done at least 10-day wait period before radiation therapy. Additionally, preventive considerations like secretagogues of pilocarpine should be given because radiation therapy can also affect the salivary glands, which can result in xerostomia. So this xerostomia can cause radiation-induced caries. So topical fluoride applications can also help to control the dental caries and artificial salivary supplements can also be helpful. So denture should be regularly checked to avoid ill-fitting processes that is causing chronic trauma. So when should we extract the teeth? As we have discussed in the previous slide, it should be before radiation therapy. At least 2 to 3 weeks should be given an interval before starting radiotherapy after extraction. So the technique should be atraumatic as possible along with alveoloplasty to remove the sharp bony margins and primary closure should be done. So all these should be done under antibiotic prophylaxis. So antibiotic therapy should be continued at least for 1 to 4 weeks and periosteal elevation should not be done because this may compromise the blood supply of the underlying bone, which may increase the risk factor for osteoradionecrosis. If at all patient requires dental extraction after radiotherapy, these are the treatment guidelines. First of all, before planning extraction, 1 week before, we have to prescribe the patient with pentoxifillin and tocopherol. Then after extraction, it should be continued for 8 weeks to prevent the osteoradionecrosis. Even after following this preventive regimen, the patient developed ORN. Then the antioxidant and pentoxifillin should be continued for 6 months. If the patient is unresponsive at 3 months, it should be added with clodronate 1600 mg. Clodronate is nothing but it's an anti-resorptive agent which can reduce the osteolysis. But if the patient has developed osteoradionecrosis with a large area of sequestrum, then we have to do a sequestrectomy along with extending antioxidant for a longer period of time. Even though the patient developed pathological fracture, then patient requires bony resection along with reconstruction of vascularized tissue flap.